What's going on, YouTube and fellow sheepdogs? It's One Tactical Medic coming at you. Gonna start doing some videos on first aid skill set. I think everybody should know a little bit about. If you're gonna be a sheepdog, you also need to know a little bit about the medical side of stuff. So, anyways, I watched a video the other night. Southern Pt1 did a video on medical supplies and stocking up on medical supplies. I think that's very important. I also think it's very important that you have some sort of first aid training, whether it be basic CPR or first responder or just a first aid class. But I also think that people should think about possibly taking a EMT or paramedic course. And if you do have a defense group or a retreat group, you need to make sure some people in that group are medically trained, whether they be paramedic, LPN, RN, physician assistant, doctor. In WROL, you're not going to have 911 to call. That's just all there is to it. So you're going to be on your own to take care of yourself, those around you. So I think it's important. So I feel kind of compelled to do a series of videos on first aid and different types of first aid and different things that you can do. I want to give another shout out to another channel, the Patriot Nurse. If you haven't checked her channel out, I may annotate down at the bottom her channel and Southern Pt1's channel. And there's a lot of other good channels out there. Just don't have time to mention them all. But Patriot Nurse, she is a nurse and she does have a lot of good information. So check her channel out. So anyways, let's get right into it. Worst case scenario, you come across somebody that's injured. What do you do? What's the first thing you do? Well, there's a thing called the chain of survival. First thing you want to do is tell somebody to go call 911. That's if 911 is up and running. If it's not, then it's going to be up to you. So basically what you're going to want to do first is what we call BSI, body substance isolation. That means putting on a pair of rubber gloves, just the regular latex type rubber gloves, nitrile, just anything to protect your hands. So once you've got your body substance isolation equipment on, the second thing you want to do is look at your scene, look at what happened, determine whether the scene is safe for you to proceed. And what I mean by that is, if you're in an active shooter situation, are you gonna run out there and try to grab somebody if they're still taking rounds or you're still taking rounds? That's not a safe scene. You're gonna end up with more than one patient at that point. So make sure your scene's safe. It could also be a car. Maybe it's on fire, maybe it's smoking, maybe there's power lines down on top of it. Don't put yourself in a position to become a victim. You're the rescuer, so make sure you stay in that role. Don't compound or add to the situation by getting yourself injured or those of your team injured. So, all right. So make sure the scene's safe. That's the first thing you're going to do after you put on your body substance isolation. All right. When you come up to your patient, you want to look at the patient and determine the mechanism of injury. What happened to them? Were they shot? Did they fall? Did they get impaled by something? Or are they just sick? And if they're just sick, we call that a nature of illness. Okay, so determine either the mechanism of injury or the nature of illness. You're also going to want to make sure that that's your only patient. Whether you may have two patients and you just don't see the other one. Prime example, a car rollover. You have one person trapped in the car, but you start treating that patient and then you realize somebody's been ejected and they're laying in a ditch face down in mud or something. So make sure you know how many patients you have. And then at that same time, you're going to have to triage those two patients or your patients. You're going to have to find out which one needs your help the most at that time. Okay, and triage, for lack of better terms, is a tough thing to do, especially if you're a compassionate person. It's hard to turn somebody away if they need help right then and there. Okay, and then the next thing you're going to do is, if you do have access to 911, you may need to go ahead and request additional assistance. Let's say, for example, if you live in a community where the fire department only has a BLS or basic life support response unit, and you have a full cardiac arrest. Well, you know, when you get there, if you see the patient's in full cardiac arrest, you need to go ahead and, you know, get on your walkie-talkie and call for either Metaflight or an ALS unit, you know, somebody that can push drugs on that patient. So anyways, just keep that in mind. Okay, so after we've done our BSI, our scene size up, you know, determine the mechanism of injury and the nature of illness, we're going to go ahead and do what's called an initial assessment on the patient, okay? So what you're going to do is you're going to, in your head, form a general impression of the patient. What do they look like? You know, are they alert, talking to you? Are they coherent? Or are they unconscious? You know, if they're unconscious, do they respond to pain? Do they respond to verbal stimuli? Those are things that you need to understand and you need to form an impression about. You also, when you walk up to your patient, you need to determine right off the bat if you need to immobilize their neck. Okay, that's very important. C-spine stabilization is very important. If I have a patient that's on the ground, the first thing I do when I come up to that patient is I will put my hand on their forehead to make sure that they cannot move their forehead. You know, and then if I have a firefighter around with me or somebody else, I'll tell that person, hey, hold their head, do not let them move it. You know, somebody moves their head and they have a cervical fracture, you know, anywhere in their cervical spine. I mean, if they transect the spinal column or the spinal cord at that point, it's lights out, or they're paralyzed. They'll quit breathing. The cervical vertebrae area is very, very important not to mess it up. So, okay, so you're going to go ahead and determine your patient's mental status. You know, can they tell you where they are? You know, do they know what day it is? Do they know what happened to them? Those types of things. Find out if they're mentally there. And you want to determine their responsiveness and their level of consciousness. Okay, and we have a little acronym called AVPU, which stands for alert, visual, pain, or unresponsive. They're going to fall into one of those 4 categories. So the next thing you're going to do is determine your patient's chief complaint or their apparent life threat. And what I mean by that is, what are they complaining about? If they're alert and can talk to you and they say, hey, I'm really lightheaded, I'm having chest pains, it's radiating down my arms and in my jaw, then you know that right there, that's a critical patient. They're probably getting ready to myocardial infarct on you, so you need to, you know, you're not going to stay in play, you're going to get moving with the treatment of that patient. And when I say apparent life threats, if your patient's laying there and they're unconscious and you see blood pooling around them, or, you know, angled or deformed arms, legs, or, you know, blood coming out of their ears, I mean, that right there, those are apparent life threats. You need to look for those and identify them. So once you've done that, you're going to go ahead and move on to your ABCs. Now, the thing about the ABCs, you know, airway, breathing, and circulation, you do not move from airway until you've got it established. You don't go from breathing to circulation until you have airway and breathing established. So it's kind of a weird thing. You start at the airway and you work the airway until you get the airway done. Now, if you have, you know, extra firefighters or extra people with you, you know, and you see, you know, profuse bleeding coming out of their femoral artery or, you know, something like that, you can direct somebody to go ahead and address that wound. But your primary focus is getting the airway stabilized, okay, or what we call patent. Basically, you know, it's kind of like this. Without an open airway and adequate ventilation and oxygenation of the tissue, pretty much all of your other medical care that you're giving is futile, and therefore your patient will deteriorate and die. So airway is very, very important. There's 2 parts of the breathing. You know, the breathing is when you inhale, that takes energy. When you exhale, that's passive. So airway is one of those things where you have to get it patent. You need to assess the airway. And what I mean by that is, I'll go ahead and get my stupid mannequin here. I'll see if you can see my mannequin. He's going to be my helper. So you want to assess the airway. Okay. You want to open the mouth, and you can do that one of 2 ways. You can either do the old-fashioned head tilt chin lift method, or you can grab on the sides of the jaw and pull up. If you suspect they're a trauma patient, you pull up on their jaw and open their mouth. That's called a jaw thrust. Okay, so you want to examine their airway. You want to make sure that they don't have any gurgling, you know, any blood coming up, any vomitus, any secretions. At that point, you're going to want to insert either an OPA or NPA. These are airways. This one goes in the nose, this one goes in the mouth. You don't want to use this one if you suspect that the patient has a basilar skull fracture, or basically a skull fracture to the back of their neck. Okay, big no-no. And this one you've got to be careful with, because if the patient has a gag reflex, you could make them vomit, which you're going to have, suction ready. And this one, I've also heard of possibly vasovagal stimulating people, which can cause heart arrhythmia. So anyways, so you want to take your airway, you're going to measure it from the corner of their mouth to the tip of their ear. You would insert it just like this, and as it goes in, you're going to rotate it as you're pushing it in, and that's going to hold the tongue pretty much off the airway. One of the biggest airway obstructions in a patient is their tongue. A lot of people don't realize that. So if you come up to your patient, you do all the stuff that we've talked about before, and their airway is still occluded, the first thing you want to do is reposition that airway. Lift up on the jaw again. Okay, make sure, it could just be a simple thing where the tongue's in the way. Okay, so always try to reposition your airway before you start going to any type of adjuncts, airway adjuncts. Okay, so airway is important. It's basically one of those things where, once you get the airway established, if you have to do any type of suction, you go ahead and do suction. This right here is just a big syringe with a catheter on the end of it that I can suction with if I need to. The next thing we're going to do is the whole breathing side of it. Okay, so we've done airway. We'll make sure the airway is open and patent. Breathing, you want to assess a few different things here. Okay, you want to assess if it's adequate breathing or inadequate breathing. What I mean by that is, you want to see how they're breathing. Do they have good chest rise and fall? Okay, you want to look at the rate of their breathing. Is it normal? Is it within normal limits? Is it rapid? Is it slow? Is it agonal, which means, like they're really struggling to breathe? Or is their breathing not there at all? If that's the case, then you need to start breathing for them. You also want to look for the rhythm. Is the rhythm of their breathing regular or irregular? Or is it extremely irregular with pauses, in between the breathing? You want to identify the depth. Is it normal breathing? Is it deep breathing where they're really struggling, or is it real shallow where they're just kind of puffing? You want to assess the the working part of the breathing. Is it labored? Are they having a real hard time breathing? You also want to assess any type of noises, and you're going to have to do this with you can do it with your ears. You want to hear any type of bubbling, wheezes, or what we call stridor, any type of gurgling. And you also want to auscultate, and that's a fancy word for basically using your stethoscope, and you want to listen to all the lung fields and just listen for different things. You may hear wheezes, you may hear rales or rhonchi, which it's kind of hard to explain what those are on the video. It's kind of one of those things where you have to know what you're listening for. So anyways, once you get the airway secured, you're going to go ahead and start breathing for them. This is a BVM, bag valve mask. You basically just put this over your patient. Make sure I got that right. Okay, just like that. And you're going to squeeze. And you're going to breathe for them. Okay, that's how a bag valve mask works. You can pick these up on Amazon. Highly recommend everybody has one of those. Okay, so the breathing is very important. You need to make sure that you're breathing for them, because if they're not breathing for themselves, then they're gonna diminish real quick. Some of the signs and symptoms that you want to look for. Do they have any blue tint around their lips? Is their cap refill bad? Capillary refills when you squeeze your fingernail, and how quick does the redness go away and normal flesh tone come back? Are they going into shock? Are they clammy and cold and sweaty, or are they warm, pink, and dry? You always want your patient to be warm, pink, and dry. So you need to look for the signs and symptoms of cyanosis or not breathing, them not getting oxygen, because that's a really bad thing. So Okay, so breathing, there's another little thing I want to show you too. You know, these safety pins right here, big jumbo safety pins. In an austere environment, you can use this as an airway to move the tongue. If your patient is unconscious, you basically get 2 of these and actually pierce their tongue, 1 on each side, and tie some parachute cord in between this once you get it closed, and you can actually pull their tongue slightly out of their airway, and with that parachute cord you can tie it to their chest rig, or maybe they've got magazine pouches. You could wrap the parachute cord around that, or you could wrap it around a button. So safety pins can also be used to open an airway. It would obviously be a extreme case if you had to use it, but it has been done. So okay, airway breathing. We'll go ahead and talk kind of real quick about circulation. Circulation is basically, are they pumping blood throughout their body? So what you want to do is you want to assess their pulses, whether you do the carotid. Normally what I'll do is I'll do the carotid, and I'll also take a radial pulse at the same time. Okay, that kind of allows me to know how well they're perfusing. You want to assess for the pulse. You want to see what kind of pulse rate is it. Are they tachycardic, which means heart beating too fast? Or are they bradycardic, which means heart beating too slow? Is it a bounding pulse? Is it a slow pulse? Is it barely palpable? Those are all things that you need to take into consideration in treatment for your patient. At this time, when you're doing the ABCs, all right, we've already talked about airway breathing. Like I said, we're on circulation now. You want to assess at this time your patient head to toe, what we call blood sweep, real quick. You want to start at the head and work all the way down their body fast. And I mean, I'm talking 15, 20 seconds. You're basically going to stick your hands under their clothes, and the one thing you got to remember too is all trauma patients get naked. That's just the rule of thumb. And be discreet about that. You don't want to let everybody see their junk and stuff, but if you have a severe trauma patient, cut their clothes off. Get their clothes off. I mean, you're going to miss stuff if you don't. So at that time, doing the circulation, we're going to go ahead and do our blood sweep, head to toe, real quick. Identify any place where they may be bleeding out, and you're going to stop it or direct somebody to stop it at that time. You want to assess this skin, color, temperature, texture, and turgor. Turgor means what's like the strength of the skin. And you want to assess the capillary refill. Like I said, you basically, on cap refill, you take their fingernail and you pinch it. I don't know if you can see that, but the color will come back. Okay, if the color doesn't come back real quick, they're probably getting shocky on you. Okay, so we've done the circulation. Okay, and the circulation thing too, this is the point where if you take their pulse and you don't feel a pulse, what's your next step? Well, CPR, AED time. So anyways, you also, after you've done the ABCs, and I know I'm kind of going through this, but you want to, during the circulation part of it, you want to start treating for shock too. Shock kills people. Shock is a killer. So anyways, this is this is kind of the first things that you want to do. Like I said, it's basically determine your scene. Is your scene safe? Take body substance isolation precautions. Put gloves on. Determine the mechanism of injury, the nature of the illness. Make sure you only have that one patient. Make sure somebody did get blown up into a tree or something. Request additional assistance if you need an ALS intercept or advanced life support, or a helicopter or something like that. Do your initial assessment of the patient. Verbalize the general impression. Tell yourself, man, what do I have here? What's this patient look like? Determine their mental status and level of consciousness. Determine their chief complaint and apparent life threats. Then it's airway, breathing, circulation time. Remember, you don't go from breathing back to airway, or excuse me, you don't go from airway to circulation, or you basically start at airway, and you work airway until you've got an open airway. Then you worry about breathing. Then you go to circulation. And if something with your patient goes bad, you may have to go back to airway and start all over again. Airway, breathing, circulation. Treat for shock. Shock kills people. I will do a whole video on shock, because shock that's a bear in itself. So anyways, I hope this helps. Like I said, this isn't meant to be a medical course by any means. It's just some talking points that I think are important for all preppers, sheepdogs, to kind of have a working knowledge about first aid. So feel free to leave me any comments, questions, or observations. My next videos, I'm going to try to have some actual mannequins and stuff like that so you can see a little bit better instead of me using my little styrofoam head. But hey, we may have to use him a little bit longer. So alright guys, this is One Tactical Medic. I'm out. Thanks for watching.